Hyponatremia is the most common electrolyte imbalance seen in clinical practice. It affects about 5% of the general adult population and can impact up to 35% of hospitalized patients. This condition is defined by serum sodium concentration below 135 mx/L, most often resulting from water retention rather than sodium loss. Understanding hyponatremia is crucial because its symptoms can range from mild and barely noticeable to severe and life-threatening. In this video, we'll explore what hyponatremia is, why it happens, and how it's managed, starting with the basics of sodium balance in the body. Hyponatremia is not just a laboratory finding, it has real-world consequences. While only about 5% of adults in the general population are affected, the prevalence skyrockets in hospitals where up to 35% of patients may experience it. This is especially true for those with underlying health conditions or those receiving certain medications. The high prevalence in hospitalized patients makes it a significant concern for healthcare providers, as it can complicate recovery and increase the risk of adverse outcomes. Let's look at why this imbalance is so common in these settings. Hyponatremia is characterized by serum sodium level below 135 mx/L. Sodium is a vital electrolyte that helps regulate water balance, nerve function, and muscle contractions. When sodium levels drop, it's usually due to the body retaining too much water rather than losing sodium itself. This dilution effect can have various causes, from medical conditions to medication. Recognizing the threshold for hyponatremia is important for timely diagnosis and management, as even mild reductions in sodium can have significant effects on health. Sodium plays a crucial role in maintaining the body's fluid balance, transmitting nerve impulses, and supporting muscle function. When sodium levels fall, water moves into cells, causing them to swell. This cellular swelling is especially dangerous in the brain, where it can lead to increased pressure and neurological symptoms. That's why even small changes in sodium concentration can have wide-ranging effects, making early recognition and management of hyponatremia essential for patient safety. Hyponatremia can present with a wide spectrum of symptoms. Many people experience no symptoms at all, especially if the sodium drop is gradual. When symptoms do occur, they often start mild, such as weakness, nausea, or headache. However, as sodium levels continue to fall, symptoms can become more severe, including confusion, vomiting, seizures, and even coma. The severity and speed of onset play a big role in how dangerous hyponatremia can be. Hyponatremia can be classified as acute or chronic, depending on how quickly it develops. Acute hyponatremia occurs in less than 48 hours and is more likely to cause severe symptoms due to the brain's inability to adapt quickly. Chronic hyponatremia, developing over more than 48 hours, allows the brain to adjust, often resulting in milder symptoms. However, both forms can be dangerous if not managed properly, especially if sodium levels drop below 125 mx/L. Severity of hyponatremia is often categorized by serum sodium levels. Mild hyponatremia ranges from 130 to 134 mx/L, moderate from 125 to 129 mx/L, and severe is anything below 125 mx/L. The lower the sodium, the higher the risk for serious complications like brain swelling, seizures, and respiratory distress. It's important to monitor these levels closely, especially in hospitalized patients or those with underlying health issues. Sodium levels drop, symptoms become more pronounced. Mild cases may only cause subtle symptoms like fatigue or mild confusion. Moderate hyponatremia can bring on nausea, vomiting, and more noticeable confusion. Severe cases, especially with sodium below 125 mx/L, can lead to seizures, coma, and even death if not treated promptly. Recognizing these stages helps guide treatment decisions and urgency. Certain groups are more vulnerable to developing hyponatremia. Hospitalized patients, especially those with heart failure, cirrhosis, or kidney dysfunction, are at higher risk. Menstruating women are also more susceptible, as are older adults and those taking specific medications like antidepressants or diuretics. Understanding these risk factors is key to prevention and early intervention. Hyponatremia can result from a variety of causes. The most common include heart failure, cirrhosis, kidney dysfunction, and certain medications. Other causes include excessive water intake, hormonal imbalances, and conditions that stimulate inappropriate antidiuretic hormone (SIADH) release. Identifying the underlying cause is essential for effective treatment and prevention of recurrence. Most cases of hyponatremia are due to water retention rather than sodium loss. This happens when the body holds onto excess water, diluting the sodium in the bloodstream. Conditions like heart failure or SIADH can trigger this retention, as can certain medications. The kidneys play a central role in regulating water and sodium balance, and when they're overwhelmed, hyponatremia can develop. Hyponatremia is further classified based on the body's volume status: hypovolemic, euvolemic, or hypervolemic. Hypovolemic hyponatremia involves both sodium and water loss, often from vomiting or diarrhea. Euvolemic hyponatremia, such as in SIADH, features normal sodium but excess water. Hypervolemic hyponatremia is seen in conditions like heart failure where both sodium and water are increased, but water retention predominates. Hypovolemic hyponatremia, both sodium and water are lost from the body, but sodium loss exceeds water loss. Common causes include gastrointestinal losses like diarrhea or vomiting, as well as adrenal insufficiency. The body tries to compensate by retaining water, which further dilutes sodium levels. Recognizing this form is important because treatment focuses on restoring both fluid and sodium balance. Volemic hyponatremia is most often associated with SIADH, thyroid or adrenal dysfunction, or glucocorticoid deficiency. In this form, sodium levels remain normal, but inappropriate vasopressin release causes the body to retain water. This leads to dilutional hyponatremia without signs of fluid overload or dehydration. Identifying the underlying hormonal or medication-related cause is key to effective management. Hypervolemic hyponatremia occurs when both sodium and water are increased, but water retention is even greater. This is typically seen in heart failure, cirrhosis, or advanced kidney disease. The excess fluid leads to swelling and can worsen underlying conditions. Managing this type involves careful fluid restriction and addressing the primary disease process. Third populations are at increased risk for hyponatremia. Older adults, menstruating women, and those with chronic illnesses are particularly vulnerable. Medications like SSRIs and thiazide diuretics can also increase risk, especially in older, underweight women. Awareness of these risk factors helps clinicians monitor and prevent hyponatremia in high-risk groups. Exercise-associated hyponatremia is a rare but important cause, especially in endurance athletes. It occurs when excessive water intake during prolonged exercise overwhelms the kidney's ability to excrete it. While usually mild and asymptomatic, it can occasionally lead to severe symptoms if not recognized and managed promptly. Primary polydipsia is another cause of hyponatremia, often seen in psychiatric conditions or medical disorders that promote excessive water intake. In these cases, the kidneys are unable to keep up with the large volume of water consumed, leading to dilutional hyponatremia. Behavioral support and fluid restriction are key to managing this condition. Several medications can cause or worsen hyponatremia. Antidepressants, especially SSRIs and thiazide diuretics, are common culprits. These drugs can stimulate inappropriate antidiuretic hormone release or affect kidney function, leading to water retention and sodium dilution. Monitoring sodium levels in patients taking these medications is essential for early detection. Syndrome of inappropriate antidiuretic hormone secretion, or SIAD, is a leading cause of euvolemic hyponatremia. In SIAD, the body releases vasopressin inappropriately, causing water retention without sodium changes. This can be triggered by medications, stress, pain, or underlying diseases. SIAD is especially common in hospitalized and older patients. Diagnosing hyponatremia involves more than just measuring serum sodium. Doctors also assess urine sodium, urine osmolality, and specific gravity to help determine the underlying cause. For example, a urine sodium above 30 mx/L suggests kidney loss or SIAD, while lower values point to extrarenal losses. These tests guide the next steps in management. Serum and urine osmolality are important in classifying hyponatremia. Hypotonic hyponatremia, the most common type, is defined by serum osmolality below 270 m/kg. Urine osmolality helps distinguish between SIAD and other causes. These measurements are especially useful when the diagnosis is unclear or when multiple factors may be involved. Key danger of hyponatremia is cellular swelling, especially in the brain. Low sodium causes water to move into cells, leading to swelling and increased intracranial pressure. This can result in symptoms like headache, confusion, seizures, and even herniation in severe cases. Preventing rapid shifts in sodium is critical to avoid these complications. In some cases, hyponatremia can lead to non-cardiogenic pulmonary edema, especially with water intoxication from endurance sports or MDMA use. This condition is characterized by fluid accumulation in the lungs without heart failure. Symptoms include shortness of breath and low oxygen levels, requiring prompt recognition and treatment. Urine sodium levels provide important clues to the cause of hyponatremia. A urine sodium above 30 mx/L suggests SIAD or renal sodium loss, while values below 30 mx/L point to extrarenal losses like vomiting or diarrhea. These distinctions help tailor treatment to the underlying problem. Urine osmolality and specific gravity are additional tools for classifying hyponatremia. High urine osmolality, often above 100 m/kg, is typical in SIAD. These measurements help differentiate between causes and guide appropriate treatment strategies, especially when the diagnosis is not straightforward. Serum osmolality is measured when the diagnosis of hyponatremia is uncertain. It helps distinguish between hypotonic, isotonic, and hypertonic hyponatremia. Hypotonic is most common, but hypertonic can occur with high blood sugar or mannitol use, while isotonic is usually a lab artifact. These distinctions are vital for choosing the right treatment approach. Hyponatremia develops when the body's ability to excrete water is overwhelmed. This can happen due to excessive water intake, increased vasopressin release from stress or medications, or decreased kidney function. The result is a dilution of sodium in the bloodstream, leading to the symptoms and risks we've discussed. Understanding these mechanisms helps target treatment effectively. There are several types of hyponatremia, each with unique causes and implications. Hypotonic hyponatremia is the most common, with low osmolality. Hypertonic hyponatremia is triggered by high blood sugar or mannitol, while isotonic is usually a lab artifact. Recognizing the type is crucial for selecting the right treatment and avoiding complications. Severe hyponatremia, especially with symptoms like seizures or respiratory distress, requires emergency treatment. The goal is to raise serum sodium by 46 mx/L within 1–2 hours using 3% sodium chloride boluses. Airway management, oxygen, and anticonvulsants may also be needed. Frequent sodium checks are essential during the first 24 hours to avoid complications. There are two main methods for correcting severe hyponatremia: bolus and continuous infusion. Bolus infusion reaches target sodium levels faster but carries a higher risk of overly rapid correction, which can be dangerous. Continuous infusion is slower but safer, reducing the risk of complications like osmotic demyelination. The choice depends on the patient's symptoms and risk factors. Correcting sodium too quickly can cause osmotic demyelination, a serious neurological complication. To prevent this, sodium should not increase by more than 10 mx/L in 24 hours or 18 mx/L in 48 hours. If overcorrection occurs, immediate treatment with desmopressin or 5% dextrose in water may be needed to lower sodium safely. Desmopressin is often used after emergency correction to prevent overly rapid sodium increases, especially during water diuresis. While it prolongs treatment and increases monitoring needs, it's effective at stabilizing sodium levels. The recommended dose is 2-4 micrograms every 6-8 hours, tailored to the patient's response. Long-term management of hyponatremia requires addressing the underlying cause. Whether it's medication-induced, related to heart failure, or due to hormonal imbalances, treating the root problem is essential to prevent recurrence. This may involve adjusting medications, managing chronic diseases, or providing behavioral support for excessive water intake. Treatment for hypovolemic hyponatremia focuses on restoring both fluid and sodium balance. Isotonic saline or oral sodium chloride is typically used, while hypotonic fluids should be avoided. Monitoring urine output and serum sodium levels throughout treatment is essential to ensure safe correction and avoid complications. Fluid restriction is a key strategy in managing many forms of hyponatremia. The degree of restriction is guided by the urine sodium to serum sodium ratio. Mild restriction is used for ratios below 1, while severe restriction is needed for ratios above 1. This approach helps prevent further dilution of sodium and supports recovery. Sodium chloride tablets can be combined with furosemide, a loop diuretic, to help correct sodium levels. However, this combination carries risks like hypokalemia, so potassium levels must be monitored closely. Oral or enteral urea may also be used to promote water excretion and improve sodium levels. Vaptins such as tolvaptan are effective for some patients but can be costly and carry risks like thirst and potential hypernatremia. Hormonal therapy may be needed for those with glucocorticoid deficiency or hypothyroidism. These treatments are tailored to the underlying cause and patient needs. For patients with primary polydipsia, behavioral support is essential. This includes fluid restriction and strategies like using sour candies to manage dry mouth. Education and support can help patients adhere to fluid limits and prevent recurrence of hyponatremia. In patients with heart failure, managing hyponatremia involves fluid restriction and diuretics to control fluid overload. Thiazide diuretics should be replaced with loop diuretics if needed, and vaptins are generally avoided due to the risk of worsening hypovolemia. Potassium supplementation may be necessary if levels are low. Severe hyponatremia in advanced liver disease requires careful management. Diuretics may need to be withdrawn and hypotension addressed. Treatments like midodrine, albumin, or hypertonic saline may be considered in severe cases. Close monitoring is essential to prevent complications. Throughout treatment, it's vital to monitor urine output and serum sodium levels closely. This helps ensure safe correction and allows for early detection of complications like overcorrection or electrolyte imbalances. Frequent checks are especially important during the first 24-48 hours of therapy. Potassium levels often need to be supplemented during hyponatremia treatment, especially when diuretics are used. Other electrolytes such as magnesium and calcium should also be monitored and corrected as needed. Maintaining overall electrolyte balance is crucial for patient safety and recovery. Preventing recurrence of hyponatremia involves ongoing management of the underlying cause, regular monitoring, and patient education. Adjusting medications, managing chronic diseases, and supporting behavioral changes are all part of a comprehensive prevention strategy. Early intervention is key to avoiding future episodes. Hyponatremia is a complex but common electrolyte disorder with a wide range of causes, symptoms, and treatments. Early recognition, careful diagnosis, and tailored management are essential for preventing complications and ensuring the best outcomes. By understanding the underlying mechanisms and risk factors, healthcare providers and patients can work together to manage and prevent this potentially serious condition.